Okay, is it audible?
Yes,
Audible?
sir. It's audible,
Yeah.
sir.
Okay. What about the screen? Can you able to see the whiteboard?
Yes, sir. It's visible, sir.
Yeah. Okay. Okay. So today we are going to discuss about carcinoma breast staging and investigation. Okay, we'll start with the staging. The commonest staging what we are using in clinical practice is TNM staging. You all know that. Just I will briefly tell you that what do you mean by this TNM stage. Okay, T stands for tumor, N stands for node, and M stands for metastasis. So we'll start with the T stage. That is, first we'll start with TX. What do you mean by TX? That means tumor cannot be assessed. Tumor cannot be assessed. That you can call it as TX. Okay, so when you say that the tumor cannot be assessed, I will tell you one clinical scenario. A patient coming to you, a female patient, 28-year-old female, coming to you, and she is giving some complaint. That is, she already underwent some surgery 1 month back for a breast lump, and the specimen also sent for the examination, histopathological examination, and still she is awaiting for the report. Now you are examining the breast. Obviously there is no lump at all. You can't able to see any, on clinical examination you can't able to see any lump at all. In that case you can tell that is a TX. Okay, that is a tumor cannot be assessed because already the patient underwent some surgery. You cannot be able to assess the original status of the tumor. So this is called TX. Similarly, it is applicable for NX also. Okay, so where sometimes the patient underwent some lymph node biopsy in the axilla. So in that case, you cannot assess the nodal status. That is called as NX. Next, T1, which is very simple. That is a tumor size of less than 2 centimeter in size. Next, T2 is the in between 2 to 5 centimeter. So breast lump tumor size 2 to 5 centimeter, and T3 more than 5 centimeter. Then finally it comes T4A. T4, again there are 4 divisions are there. 4A. 4A means chest wall. Okay, that is the tumor is involving the chest wall fixity is there. And again, according to this stage, what do you mean by chest wall? Chest wall means only 3 structures they are mentioning in the staging, in TNM staging. Number 1, ribs. Number 2, intercostal muscle. And number 3, serratus anterior. Okay, so only these 3 structures they are considering it as a chest wall. So ribs, intercostal muscle, and serratus anterior. Okay, next to 4B. 4B means skin involvement. That means the tumor is involving the skin. Again, what do you mean by skin involvement? Okay, so you're just examining, just pinch the skin over the this location, over the lump. You can't able to pinch the skin. Then you can call it as skin involvement is present. So that is the pinchability, pinchability or rollover. You are checking if it is positive, then skin involvement is there. Or else edema is present. For example, the typical example is PUD orange appearance. Okay, edema is present, then that is also suggestive of skin involvement. Okay, so if you are seeing any patient presenting with PUD orange, ultimately your stage it comes to 4B. And similarly, other things, satellite nodules. Satellite nodules are there, then that is also suggestive of skin involvement. Next one is the 4C. 4C, which is nothing but combination of A plus B. That is both the chest wall and skin involvement. And finally 4D is the one that is inflammatory carcinoma. Inflammatory carcinoma, characteristically seen during the pregnancy and lactation. It almost mimics like inflammatory condition. That's why it's called inflammatory carcinoma, but it has got an worst prognosis. This is about the T stage. Then coming to the N stage, NX we already discussed. N1 is again that is N0. Here also T0 is there. There is no evidence of primary. NX is there. N0 is there. N1 is Ipsilateral, that means the same side. Ipsilateral mobile, ipsilateral mobile axillary lymph node. Mobile axillary lymph node is present, then you can call it as N1. Then next one is N2. N2 again, the two things are there. One is 2A. 2A is nothing but these mobile axillary lymph node, it will be fixed in nature. So 2A is fixed in nature. And 2B is only internal mammary lymph node involvement. There is no axillary lymph node involvement. Only internal mammary lymph node involvement will be there. Then comes N3. N3 only the three things are the three stages are the 3A, 3B, 3C. So what is 3A? 3A means infraclavicular involvement of ipsilateral infraclavicular. 3B is combination of axillary lymph node plus internal mammary lymph node. So we saw in 2B it is only internal mammary, whereas 3B it involves axillary and internal mammary, then that is 3B. Then 3C is ipsilateral supraclavicular. This is called 3C. Okay, that finishes of the N stage. Then we'll go to the metastasis. Metastasis is very simple, M0 and M1. M0 is no evidence of metastasis, M1 is evidence of distant metastasis. Okay, so this is about the basic TNM stage. Okay, once you talked about all these stages, we have to talk about it comes under what stage. Okay, so we will discuss that one also. Just hold on. Okay, we will discuss about the staging. You can discuss like this: stage 1, stage 2, and stage 4. Okay, so simply I will tell you that how to read this staging. Stage 1. Okay, stage 1. Just hold on. Okay, there are 4 stages are there. You can see that stage 1, stage 2, stage 3, and stage 4. Stage 1 is nothing but anything that presents with T1, T2, N0, M0. Okay, simply you can remember like this: T1, T2, N0, M0. And stage 2, which is nothing but anything that presents with N1. Okay, anything that any T with N1 and M0. Okay, and again 3, there are 3 A, B, C, like that it is there. A, B, C, like it is like that. So what you have to, which is nothing but it's a combination. Anything that presents with N2, anything that presents with T4, okay, and anything that presents with N3. So this staging you can call it as stage 3. And last one is the stage 4, which is nothing but anything that presents with M1. Okay, so stage 1 and stage 1 and stage 4 is very easy to remember, since you can see that stage M1, okay, anything that presents with, irrespective of the tumor size, irrespective of the nodal status, anything that presents with distant metastasis, then you can call it as a stage 4 disease. Similarly, stage 1 is tumor size, okay, tumor size less than 2 centimeter, any tumor less than 2 centimeter with no nodal involvement and no distant metastasis, you can call it as stage 1. Okay, so this is easily you can remember, and these stage 1 and 2 you can call it as EBC, that is called early breast cancer, EBC. And stage 3 you can call it as LABC, locally advanced breast cancer. And stage 4 you can call it as ABC, advanced breast cancer or carcinoma. Okay, so this is the classification. First you have to assess the patient. Patient will comes under what stage, whether EBC, LABC or ABC, because the treatment varies. If the patient comes under EBC, the treatment is different. If the patient comes under LABC, treatment varies. So you should know that first you stage the disease, then you can plan the management according to the stage of the disease. Okay, so this is about the stage of the disease. Next we will discuss about investigations. And first thing is, you have to confirm your diagnosis. Clinically you are assessing, and you have to confirm your diagnosis. That is the first thing you have to tell. Okay, you have to do that one. So for that, what you have to do, you have to do this one. You all know this one, which is nothing but this is a triple assessment. Triple assessment, first thing you are doing is the clinical aspect, that is the examination. What is the age of the patient and the examination, history taking, examination, all these things are clinical examination. This we are routinely we are doing. And the next one is the imaging, that is a radiological investigation. The two investigations are used, one is ultrasound, another one is the mammography. And next one is the pathological aspect, that is the FNAC or core cut needle biopsy. Okay, so why you have to do for a patient presenting with triple assessment? Because you will get a confident diagnosis in 99.9% of the cases. That's why you have to do all the three things you are combining together, and you are assessing the breast lesion. Okay, so this is the triple assessment. You all know that one, and just to keep on stressing. The same thing you have to apply if you are getting any case of breast lump. Try to assess, do the triple assessment. Okay, so we will once you are clinically you are diagnosing patient is having CA breast. The next thing is you have to confirm your diagnosis. How will you confirm your diagnosis? First thing, you have to confirm the diagnosis only by two investigation. Okay, the first investigation is, you all know that first you have to do the FNAC. FNAC, investigation of choice first. Okay, what is the role of FNAC? What will you do? How will you do? What are the materials required? What are the needle? So ideally you should use an 23, 22 or 23 gauge needle you have to use. And how to take this FNAC procedure. Okay, for example, this is a patient. The patient is having a lump. This is a patient having a breast lump. How to do on FNAC? Which is nothing but you take a 23 or 24 gauge needle, insert the needle. Okay, insert the needle, and this needle into the breast lump, and this needle has to be connected to with a syringe, either a 10 ml syringe or a 20 ml syringe. Okay, then insert the needle and insert the needle in multiple direction by after creating a negative pressure. Okay, just to pull off this piston, the negative pressure will be created. Once the negative pressure is created, the cellular material that is present within the lesion will come and deposit in the needle. After that, you take out the piston separately and needle separately, then push all the materials into a glass slide and then smear it. Okay, either two methods, either you can do it with the air dried method or by the using the 95% ethyl alcohol. By that you are using as a fixation method. So once you fixing this one, you have to analyze and try to assess that what is the exact scenario. Okay, so this is by which you can do the FNAC. FNAC has got a lot of advantages. It's a OPD procedure, cost effective, immediately you can get the result. And the disadvantage is, the main disadvantage particularly in breast is you cannot able to assess whether it is a non-invasive or invasive. Okay, non-invasive or invasive. Even though if you are can able to make out the malignant cells, but you cannot able to assess whether it is a non-invasive lesion or invasive lesion. For that only you are using that another investigation. Okay. The first time you are doing FNAC, you are not getting a proper report. What will you do? You do one more time you can do the repeat FNAC. Still it is not, it is still also you are not getting a positive report. What you have to do is, then in that case only you have to go for the biopsy. Okay. So there are some biopsies you can do in case of breast lump, and what are the biopsies and what are the indications for the biopsies. Okay, so that we will discuss. So FNAC is inconclusive, or next you are planning for biopsy. So what biopsy will you do in that patient? Okay, so there are so many biopsies are there. I will tell you one by one. First one is the true cut needle biopsy or core cut needle biopsy. What is this true cut needle biopsy or core cut needle biopsy? Okay, so this is the needle. Okay, this is a needle. Okay, so first I will tell you this. What is this true cut needle biopsy? TCNB, or you can call it as core cut needle biopsy, TCNB. Okay, so this needle, you can see that this is the needle. This is a needle, you can see that now, and this is the tip of the needle. So it has got two sheath will be there. Outer sheath will be there and the inner sheath will be there. In the inner sheath, there will be small trench will be there with the sharp end will be there. You insert the needle along with inner sheath, outer sheath together. Once you insert into the tumor, withdraw the outer sheath so that this part will come into the tumor, and again you close it. What will happen? Some part of the tissues will get deposited in this small trench, and you can take out the needle and collect this material. Okay, so this you can send it for the histopathological examination. So this is an OPD procedure. You can give local anesthesia, make a small nick, and then you can, using the special device, this true cut needle biopsy needle, you can do this procedure. Okay. Suppose if it is not available, if the true cut needle biopsy needle is not available, then what will you do? Okay. In that cases only you have to go and do that. Other two biopsies are there. What are they? Number one is incisional biopsy. Number one, it is incisional biopsy. Another one is excisional biopsy. So when will you do this incisional biopsy? Okay, so it is nothing but almost similar to that of true cut needle biopsy. There you are using a special device. Here you don't have any device. Nothing but you make an incision over the lump and go to that, take some amount of tumor tissue. This is called incisional biopsy. So without needle, you are directly taking the tumor tissue from the incision through the incision. Okay, so what are the indication? Common indication for incisional biopsy, the tumor size, if it is bigger one, tumor size more than 4 centimeter, that is the indication for incisional biopsy. For excisional biopsy, tumor size less than 4 centimeter, you can plan for the excisional biopsy with adequate amount of normal margins you have to take. Okay, so what are the precautions you have to take while planning for incisional biopsy and excisional biopsy? Incisional biopsy, what you have to do is, suppose I will put some pictures. So this is this patient is having some lump in the upper outer quadrant. Okay, upper outer quadrant. So what you have to do, suppose if it is a malignant, in future incision, what future incision you will put for this modified radical mastectomy is classic Stewart elliptical incision. So you will put an incision like this. Okay, when you are suspicious of malignance and you are planning for incisional biopsy, what you have to do is you have to put an incision so that incision has to be included within the further upcoming incision. So that means your incision should be within this border. It should not cross that one. It should not cross beyond this future incision. So that precaution you have to take, number one. First one is the incision, where to put the incision. Number two, you should not use diathermy. You should not use diathermy. Okay, because when you are using a cautery, electrocautery, what will happen? It will damage the adjacent tissue. So you can't able to get a proper pathological report. So this is the second thing you have to do. Third one, you should not keep any drain. Okay, since if it is a malignant and it will tumor can, there will be tumor seedling will be there. So for that, try to avoid that one. Should not keep any drain. So you should not use drain. You should not use electrocautery. Your incision has to be within the further upcoming MRM incision. So in that way, you have to plan. So this is for incisional biopsy and excisional biopsy. And one more biopsy also there in the carcinoma breast, that is edge wedge biopsy. Edge wedge biopsy. So this ideally indicated a patient presenting with breast lump with ulcer over the breast lump. So a lump is there, over that you are getting some ulcer. In that case, you take an edge wedge biopsy. So you have to take an as like a wedge, you have to take and include and take it in the peripheral aspect, include the edge of the ulcer. This is called edge wedge biopsy. Ideally indicated a patient presenting with breast lump with the ulcerative lesion over the lump. In that case, you can plan for the edge wedge biopsy. Okay, so these are all types of biopsies you can plan according to the condition you have to plan. Okay, once you confirm the diagnosis, next thing is you have to plan for other investigation. What are the other investigation? First one is the mammogram. Mammogram. What is mammogram? Mammogram is nothing but an X-ray. It is an X-ray, soft tissue X-ray. So where you are using minimal dose that is 0.1 centigrade radiation is used to take the pictures. And there are two views you will take. One is medial. Just hold on. This you will take a mediolateral oblique view. Can you see the image now?
Yes, sir.
Yes, okay. So you are taking the two views. One is what you are calling, this is first view, it is called as craniocaudal view. Craniocaudal view, which is nothing but the breast will be compressed. Two plates will be kept, then breast will be compressed between the two structures like that. One is from the cranial, another one from the caudal. So, and you take then image, that is called craniocaudal. This is craniocaudal view, and this one is the mediolateral oblique view. You can see that the plate is kept in such a way that is one on the medial and another one on the lateral aspect and in the oblique view. Okay, so this is called mediolateral oblique. So these two views are essential while you are taking mammogram. So mediolateral oblique view and craniocaudal view. These two views are the common views are taking in the mammogram. Next one is, this is basically a screening test. Basically mammogram is a screening test. So which patient you can do this mammogram is ideally, roughly I am telling, that is a patient age more than 40 years, because the density of the breast will be very less. Density, the breast will be very less, because once the density is very less only, you can plan for the you can plan for the next further assessment. Whereas ultrasound is the one where if the breast is dense in nature, then it is useful. So USG you can plan for less than 40 years. Less than 40 years you can plan USG, and where because the breast tissues are more dense, in that case ultrasound work very well. Okay, so this is about the mammogram. And what are the features to say that the patient is having malignancy by mammogram? There are so many findings are there to say that patient is having carcinoma breast. First one is architectural distortion. Architectural distortion. Okay, the entire, you can see that lobular duct, all these things you can see in that mapping, and it will be completely distorted. It will be completely distorted. So that is the first thing. And second one, the duct dilatation. The duct will go for dilatation, and main thing is calcification. You will get micro calcifications. Okay, so that you can pick it up very easily in mammogram, micro calcification. And other calcification, that is the mass will be this shape, that is you can describe as stellate mass. Stellate mass with margins are irregular margins and spiky projections. Spiky projection. Okay, so these are some characteristic features of mammogram, suggestive of malignancy. Okay, and other important thing is skin will be thickened. Skin will be thickened and the nipple will be retracted. So these are some features of malignancy. When you are doing mammogram, these are some features of malignancy. Okay, so this is these are all features. We'll go to that. How to assess this grading? So this grading is there. You know this grading, which is nothing but Birod's grading. Okay, Birod's grading is there. Birod's grading, which is nothing but assessment is there. 1 to 6 is there. 0 is incomplete assessment. 0 is incomplete assessment, and 1 is negative. Okay, so you cannot be able to comment anything. So usually you need an annual screening. And 2 is benign finding. The future suggestive of benign finding. 3 is probably benign. Okay, and 4 is suspicious. Suspicious abnormality is there. 4, that is biopsy should be done. And 5 is, that is highly suggestive of malignancy. Okay, so immediately biopsy taken and you should go and do the procedure. And 6th one is the known case, already proven biopsy. Already biopsy is proven and you are taking mammogram, that is also, that is you are seeing the future suggestive of mammogram. So this grading is called, what you are calling as Birod's, which is nothing but breast imaging reporting and data system. Okay, so this is very important. This Birod's is applicable for mammogram, then ultrasound, then MRI. Okay, for all the imaging methods you can use this Birod's grading. So this grading is very essential. And the next one is what is the role of ultrasound? Already we discussed about mammogram. And next one is the ultrasound. So ultrasound, how it helps? I already told the age group. Younger patient, always it is better to go for the ultrasound. That is less than 40 years, I already told. Then what is the use of? Main thing is it will differentiate whether the lesion is cystic or solid. If cystic is there, you can do the ultrasound guided aspiration. That is the first thing you can do. Okay, and you can do if it's solid is there, you can do the USG guided. Either you can do the FNAC or you can do the ultrasound guided biopsy. And the next one is sometimes there are some impalpable lesion. Okay, so that cases you can pick up by doing the ultrasound. Okay, so these are the some uses of the ultrasound, particularly in a breast lesion. And next one is what is the role of MRI? And MRI, when will you do the MRI? MRI is ideally indicated for the high risk cases, particularly patient already having the familial history, that is the first degree relatives affected, or BRCA1 positive. In that cases you can plan for the MRI. Or you are having post-operatively patient is having some scar is there, you want to rule out whether that is due to the recurrence of the malignancy or only scar is present. So that also you can rule by doing the MRI. So mainly for the high risk category, okay, MRI. So this particularly you can do in the lobular carcinoma. When you are suspecting patient is having lobular carcinoma, in that case you can do the MRI. Okay, so these are some indications for the MRI. Okay, so once you complete this investigation, since it is a malignancy, you can go and plan for the metastatic workup. Okay, so where all the metastasis you will get, commonly the metastasis, the breast, it will spread to this condition. Okay, through the bloodstream. Commonly it will spread through the bloodstream. Either it can spreads to the lungs, So lungs commonly it will present as a pleural effusion, not as a metastatic deposit. So malignant pleural effusion, by taking the simple chest X-ray PA view, you can rule out whether pleural effusion is there or not. Okay, if brain is there, if brain is metastasis there, you are suspecting, in that case you can plan for the CT brain. You are planning CT brain to rule out the space occupying lesion. And liver, ideal investigation is ultrasound of the abdomen. Ultrasound abdomen and find out these lesion. And it can spread to the bones. So bones we already discussed is commonly it spreads through the vertebra and all the proximal end of the humerus and femur and all the flat bones like ribs, scalp and pelvis, it will reach. Okay, so commonest is the vertebra is the commonest one. Okay, so when you are suspecting some bone involvement, it will produce a pathological fracture. So you do investigation called total skeletal survey. That means you have to take the X-ray of all these parts. What I told, you can take the vertebra, lumbosacral spine, or thoracic vertebra X-ray, and then proximal end of the humerus femur, take an X-ray. This is called total skeletal survey. So nowadays we are not using this total skeletal survey. Instead of that, we are using the PET scan to rule out the metastasis. Okay, so this metastatic workup you have to do, see to that whether the metastasis there or not. Once you are doing all this investigation, then only you can come to that whether no metastasis there or not, you can assess. Okay, so these are all the investigation. Okay, I think I covered completely that basic what are the things you have to see in the investigations. Okay, any doubts, any queries?
Sir, what about hormonal receptivity, sir? We do that for breast carcinoma.
Hormonal receptors, no, that ideally if you are doing biopsy, no, true cut needle biopsy, so that is one of the advantage. For example, when you are doing FNAC and true cut or biopsy, any biopsy, incisional, additional advantages you can plan for the hormone receptor assay. So that is very important. That is, you can plan for the estrogen receptor, you can plan for the progesterone receptor, and then you can HER-NEW also you can receptor study you can do. So once the receptor study is mainly useful in the post-operative management, that is a hormonal therapy. You want to give hormonal therapy or not? Based on that you can do, or else once you are planning a modified radical mastectomy itself, thus from that specimen itself you can send the hormonal receptor study. You can study from that specimen also. Advantage, you can do biopsy itself. From the biopsy specimen itself, you can able to assess that hormonal receptor assay.
Thank you.
Okay.
Sir,
Yes.
Sir, mammogram, how often are we supposed to take the mammogram, and should everyone have a mammogram screening?
You are asking that all female they should undergo, like that you are asking, or?
Yes, sir. Or only at-risk individuals should have a mammogram screening.
Only commonly it is not routinely indicated. In our country, it is not commonly indicated. In the Western, it is indicated. But here, what is when there is a previous breast lump is there, already patient underwent some surgery or some pre-existing history of breast lump and surgery underwent, definitely it is indicated. Not a normal patient, it is not necessary to undergo that 40 years mammogram screening, not like that. But when there is an history from the patient itself or from the first degree relative are affected, then definitely you should undergo that basic screening test.
Okay, thank you, sir.
Okay, ma, welcome.
Hello, sir.
Yes.
Sir, நீங்க இந்த அல்சரேட் ஆன லம்ப் வந்து எட்ஜ் வெட்ஜ் சொன்னீங்க சார். அப்போ ஃபில்லோட்ஸ் கூட வந்து வந்தபோது we can do அந்த சேம் biopsies.
No. See, phylloids, the difference between carcinoma and sarcoma is entirely different. Phylloids you can differentiate it by clinical signs itself, okay? Because the lump will be carcinoma, the lump it won't be that much bigger, whereas phylloids it will be very bigger. So that is the first clinical finding, and you can see that the skin will be go for necrosis and there will be pressure necrosis. Even you can able to see the dilatation of the veins. So clinically, by clinical examination itself, you can rule out whether that one is a carcinoma or phylloids. So once you are suspecting malignancy, you can plan for that one.
Okay, sir.
Ulcer, that also it will produce an ulcer, but it's just a pressure necrosis ulcer. But here it will be presenting as like a typical malignant ulcer.
Thank you, sir.
Okay, ma. Yeah, thank you, ma. Thank you. No queries, we will finish off. No queries, no? Apurva?
Yes, sir. No doubt, sir.
Okay, ma. Okay. Okay, ma. Thank you.
Thank you, sir.
Okay, thank you.